Thank you very much for this gentle introduction. Before we start, I would just pay tribute to somebody who died last night, and maybe our foreign colleagues don't know her. She was a very prominent political person in France, and over the past 30 years, she was regularly the preferred political person of all French people, regardless of political side. She was deported to the concentration camps at age 16, and this was something very founding for her. In 1974, she was Minister of Health. In 1979, she was the first woman president of the European Parliament, and she was again Minister of Health in 1993. What she will be most remembered for, and especially by us women, is that when she was a young woman in 1974, she became Minister of Health under the presidency of Giscard d'Estaing, who was a right-wing president. She was also from the right wing. Regardless of all that, regardless of a lot of pressure, the negative pressure from her colleagues, she was able to pass this anti-abortion law a few months before she arrived as a minister. And we've been very, very thankful to her for that. So now on to neurectomy and hyperselective neurectomy. You've seen that this is a term we've been using. The idea was first brought forward by a German surgeon named Stoffel, and you can see here a picture of Stoffel. You know, no mask, no nothing, no hat, maybe gloves, we're not sure.
Nothing's changed then.
So what was the basis for that? The base is to reduce spasticity, but without suppressing the useful muscle tone. And of course, this is only indicated, we'll come back to that, for spasticity and not for muscle contracture. Or if there is also muscle contracture or other deformities, we're going to have to add other procedures. There are roughly two types of way to deal with that nowadays, and one has been published on by several French teams. By the way, this is not so much spread in the English-speaking countries so far, but in France there is a lot of experience with that, and the team from Lyon and the east of France have published on that, and they do this partial neurectomy at the trunk level. They have very sophisticated electrical stimulation, which at the trunk level, so they say, allow them to distinguish the different fascicles, whether motor, whether sensory, and cut whatever they need to cut. So there are obvious advantages to this technique. The approach is very limited because all you have to do is go to the trunk of the nerve, but there are some limitations which to us were a little bothering. It relies solely on electrical parameters, and we have learned since that there is a lot of variability of the anatomy of the motor branches, and we have been concerned that they may, by this technique, miss part of the nerve branches. They may also injure some sensory branches. When we know the arrangement of nerve fascicles described many, many years ago by Sunderland with all this crossing of nerve fibers, this is a little worrying. And the other technique has been described by Brunelli, an Italian surgeon, many, many years ago, or has been rediscovered, I should say. And what his target was to get all the way down to the interface between the motor nerve and the muscle, to where the nerve enters the muscle, and perform the resection at that level, at the very level of the nerve coming into the muscle. His advice was to cut one half of all the motor branches, but he came back to that a few years later in another publication saying we had too many recurrences, so you need to cut 2/3 of those branches, and this is pretty much what we follow now. So the advantages of this technique are that it is absolutely selective. You cut exactly what you want to cut for each muscle, and you also have a harmonious denervation. There are many nerves have different branches, so you are sure that you are going to denervate sequentially all the parts of the muscle. It is quantitative. If you want to do a little bit of denervation, cut only 1/2. If you want to do a lot of denervation, cut 9/10. And of course, there is no sensory disturbance. So we have followed this path, and first we were curious to find out exactly where the motor branches ended up in the muscles. And thanks to our wonderful residents, some of whom are here, we did 3 studies. All of those were published in the literature in 2015 and 16, and we did a standard dissection of all these nerves. And this is here the study by Adeline, who's here, of the musculocutaneous nerve, and she showed very clearly that there are 1 to 5 branches for the biceps, 1 to 3 branches for the brachialis. So this is this can vary a lot. And the recommendation after this work is to dissect the musculocutaneous nerve between 18 and 75% of, we had a pointer, of the arm length. And obviously, you know, this is far away. Oh, that's the one, thank you. This is far away from the previous descriptions, you know, with those limited incisions. Same for the median nerve. That was Catalina Parro looking at all the muscles. And the median nerve is a big problem because it's highly variable. What we know is that the first branch is always for the pronator teres. It can be alone or in association. What we know is that there is a single trunk for the FCR, usually in association with others, and all the rest can vary. And you see those 2 very, very different dissections here. So the median nerve is a problem, and I'm not sure how you can deal with the median nerve without going all the way down to each individual muscle. This is the branches to the FCR, and you see those branches here quite clearly here, and here it's easy to do partial denervation, hyperselective. For the finger flexors, this is a problem. FDS has branches that can start very, very high and very low on the median nerve, and it is not possible to dissect those branches unless you release the proximal insertion of the muscle. And you see here the muscle has been turned over like a page of a book in order to reach that. Of course, in the clinical situation, it doesn't seem like a good idea. And same for the FDP. All those branches to the FDP are under the muscles, and so it's very difficult to do. So for the median nerve, our experience is that nerve stimulation is required, and selective neurectomy is not suited for the finger flexors. It is, however, for the thumb flexor, which is down lower. On the nerves, that was Renata Polos, and she showed very clearly that there are 1 to 2 branches for the FCU and 1 for the FDP. What she showed also that is quite interesting is that you have to raise the nerve in order to find those branches. This is a technical tip which is interesting. Very often in the clinical situation, we will want to do median and ulnar nerve, and this would be our recommendation, this L-shaped incision till mid-forearm nerve stimulation. Don't forget to elevate the ulnar nerve. So as indicated earlier, HSN is only indicated for spasticity without contracture. And if there is contracture, or if we want to do some other things, we are going to have to associate other procedures in order to rebalance the forces. So we looked at the literature, and this was done by my colleague Mathilde Gras, and only 14 articles gave us satisfactory answers on the result and the long term. But when you look closely into these, The majority of them are for non-functional hands and often after failure of other treatments. So we decided to undertake a prospective study and see if we could apply this technique to functional cases, what was the long-term result and what was the recurrence. So we started slowly this study in 2010, and I'll show you our result until 2016. There were 47 patients included, accounting for 52 hyperselective neurectomies. All patients but one had preoperative botulinum toxin, often several times. We don't have time to go into that, but that's part of the decision making, of course. Evaluation was done pre-op, 4 to 6 months, and last follow-up. And you see that our latest follow-up is 27 months, and we're hoping to include more data and continue this study in the future. This is pretty standard evaluation, range of motion, muscle strength, evaluation of spasticity with Ashworth and Tardieu scales, and the functional outcomes for non-functional patients, this notion of patient contract. Here we have to stop for 1 second. It's very nice to evaluate purely the spasticity, but often we're doing other procedures. So here we have a problem. When we evaluate our results, there is obviously some other things that we evaluate together with it. But we haven't found any other way out. It doesn't seem possible to tell the patient, okay, we're going to do just the neurectomy and then we'll do the rest of the procedures. This is contrary to what we want to do. So there is a bias here, and we don't know how to escape this bias. So very briefly, this is a series. We operate both on children and adults, and we did separate them because we were interested to see if there was any difference. 25 children, 22 adults. Age at surgery is old in children. We would like to operate children earlier than that, but they don't come to us all that early. 41 years of age for adults. Etiology, not surprisingly, cerebral palsy in children and stroke in adult patients. The objective at surgery, this was a little bit of a surprise to us. Nursing, pretty much the same in children and adults, and all the same for function, pretty much the same. The one difference, and I'm sorry I've moved that around, the one difference is what we have called social goal. Social goal would be called by other aesthetic or cosmetic goal. This is something that teenagers are extremely interested in. Teenagers don't care about function. When they have CP since they were born, all they want is this elbow to be down and this wrist to be straight. And for them, it's a very important goal, and I don't see no reason for saying, no, we won't operate just for these reasons. So 133 muscles were involved, mainly biceps, as you see, and mainly wrist flexors. And lately we have started a study also on first web space muscles, and it seems to be quite interesting. As I said, associated procedures, they were performed in 35 cases, mostly lengthening. And you see that we went on to do other surgeries in those patients, either on a different joint or, and this we have also to take into account when we are looking at our results, of course, and it is another bias. Joints involved mostly elbows, both in children and in adults. I cannot show you all our results, and we are going to focus on adults' elbows and children wrists because they are pretty significant of the rest of the series. Every time a number is in green, it means improvement. When it comes to yellow, it is a decrease, and red, fortunately, there is no red in this figure. But what we see here is that we find quite interesting is that, we have improvement of all parameters, and at 16 months post-op, which was the last follow-up, all parameters keep improving or remain stable, except the Tardieu scale, which decreased a little bit. Patient satisfaction was extremely high in this group of patients. This is one of our standard results. Here, dynamic deformity of the elbow and the wrist. He's 16 years old, and after this is 22 months after hyperselective neurectomy, and you see that this was pure spasticity, and this is pretty our less favorable result of elbow contracture. He was 43 years old. That was a head injury. Post-operative, there was 2 post-operative events, a lot of pain, and a humerus fracture 9 months after the surgery. However, this was a clinical picture pre-op. He had no movement whatsoever of his elbow, and this is his active motion at 14 months post-op. Wrist flexors, we're going to look at the children, 12 cases. You see the drastic improvement of the spontaneous posture, and that is what they want, as stated earlier. This is extremely interesting. Antagonist strength has improved greatly, but at the same time, the strength of the flexors has not decreased, and that was a very reassuring data throughout all of our series. Again, satisfaction is quite high. We have from that we have modified our way of thinking a little bit, and in those patients who have not only spasticity but a pretty strong contracture, we now go on directly to doing both at the same time, hyperselective neurectomy and lengthening, especially for the elbow flexors. This is an ongoing study, and we are in the process of analyzing it, but we have already operated on 14 patients, and you see that what exactly we do varies. We have a follow-up of 14 months. Range of motion gain is 30 degrees, but more important is the displacement of the range of motion towards extension. Again, no loss of strength of the elbow flexors, and a nice decrease of both Ashworth and Thaddeus scale. And this is one of those patients. He is a cerebral palsy patient, now at an adult age, and this was the pre-operative aspect, and you can see here the Tardieu, and per-operative with a hyperselective neurectomy, lengthening of the biceps and the brachialis, and this is the current status now at 20 months post-operatively. And he has totally negativated the Tardieu and the Ashworth scales. So as a conclusion, I think that we can confidently say that hyperselective neurectomy is effective on spasticity, and we have seen all that. Evaluation of results is difficult. We don't have the solution for that because of combined procedure, and our follow-up is only 29 months, and we are going to continue with this study. Thank you very much.